Ladies and gentlemen, welcome to the Health and Wellbeing Board of the 24th of November 2021. Thank you. We've got a very interesting agenda this afternoon, and I'm certainly looking forward to it. As always, we'll endeavour to finish as close to 4 o'clock as possible. We got the Chair's report, we got the Better Care Fund, we got suicide prevention, domestic abuse, and children and young people's mental health, followed by the work programme. So I'm going to start with agenda item 1, which is the minutes of the last meeting, for noting of their correctness rather than for comment. Pages 1 through to 8. If you could wander through those pages and tell me if you've got anything that needs to be corrected. 1, 2, 3, 4, 5, 6, 7, 8. Okay. Yep. Okay. Can I have approval for the minutes of the last meeting? All in favour? Fantastic. Now I'm going to do apologies for absence, and over to you, Martin.
Thank you, Chairman. So the apologies I've received for today are from Councillors Sue Shaw and Lynn Schuler from Bassett Law, Councillor Marion Bradshaw from Mansfield, Councillor Abby Brennan from Rushcliffe, Kevin Dennis from the Office of the Police and Crime Commissioner, Dr Jeremy Griffiths, the Vice Chair, Melanie Brooks from the County Council, Lucy Dadge from the CCG, and Idris Griffiths from Bassett Law CCG.
Thank you, Martin. So we're going to move to item number 3, which is declaration of interest by members and officers. If anybody has a disclosable pecuniary or private interest in any of the items forward, please put your hands up and declare it now, or if you remember something during the discussion, just inform us at that time. Thank you. Item number 4, the Chair's report. Those of you present at the last meeting will remember that Bryony did her absolute best and got up to 99 individual points. She showed a lot of restraint this time round and only managed to get to 89. I'm presuming that you've all been through them and found the items that are of interest to you. There was a couple that jumped out, particularly around COVID. You'll have seen that Europe is in turmoil. Austria has gone into lockdown. Compulsory vaccination has been talked about throughout Europe, and yet we seem to be doing pretty good. That's down to the vaccinations. That's down to first vaccination, second vaccination, and now booster vaccinations, and the high uptake rate. In terms of the actual vaccinations, the latest figures show 81.9% of the population over 18 had 2 doses, which is quite a staggering achievement. We'd be the envy of the world, I would say. And the booster jabs are now out. It says that they've been offered to over 50s, but they're down to over 40s now, and the take-up is huge, borne out by the fact that if you've booked one and you go and try and get it, you could be waiting for quite a while. It's been very, 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 very popular, and clinics have been run all around Nottingham to get those booster jabs in. It's very interesting that people have had their boosters and they feel that they're immune to COVID, and they've had their first and second vaccines. But the Lancet recently brought out a report on households and shown of doubly vaccinated individuals within a household where COVID existed, 25% of them got reinfected. So the booster program itself is designed to try and build back up the level of antibodies within the body. So if we are vaccinated, we develop 2 lines of response. The first is we get antibodies, which prevent us getting infected, and then we get T cells and B cells within the body, which treat the infection once it gets into the body. It's been shown that probably at around 3 months after the double vaccination, the immunity through antibodies starts to wane a little bit, and therefore that's why we can still get infected after being doubly boosted. But because of the response within the body of the B and T cells, we have an attenuated or a much milder infection, resulting in less hospital admissions and less deaths. But it shows you that double vaccination, it does wane, and the importance of getting out there and encouraging everybody to have those boosters. Just as important is the fact that the challenge is always whether or not a variation or a variant develops, and number two, anti-vaxxers trying to persuade people not to do that. So very important. We're doing fantastically well, but it's important to just keep up that momentum. At the same time, we've got the flu campaign. The nice thing about flus and getting the flu people vaccinated is that if you're vaccinated against flu, then we know that you've got the flu vaccination, and therefore you may not have flu. If you're vaccinated against COVID, you may not have COVID. So it actually helps us differentiate a little bit in that sense. But we're vaccinating more people than ever against flu this year. On a bad year, you could have up to 14,000 deaths from flu. This was before COVID ever existed. So flu could be anywhere between 6,000 on a mild winter up to 14,000. So it's still an important cause of death over the winter period, and we're still focused on flu just as much as we are on COVID. So that's where we are with the COVID situation, doing very well in comparison to our other neighbours. Sheila.
Can I just ask you, I do volunteer at COVID centres.
Yes.
And a lot of people come and say, is it safe to have the flu jab same day as the COVID jab because they've been double injecting on day?
The answer to that is
and
yes.
I said, well, I've had mine and I feel all right. You
Yes.
know?
Everybody's an individual, you know, who hasn't come away with a bit of a sore arm or some aches and pains or a slightly high temperature or a slight headache, etc. So the actual answer is that it's perfectly safe to have the two of them on the same day, but you would obviously give them in opposite arms. If you had to give them into one arm, you'd separate them by probably 1.5 to 2 centimetres. Jonathan, do you have anything to add to the COVID programme?
Really briefly, just to emphasise again, yes, just how effective the vaccines are, both the COVID vaccines and the flu vaccines. But it's really important that each of us remembers that alongside that, even after we've been vaccinated, we need to keep going with the test and isolate, with the frequent hand washing, the use of the face coverings when we're in crowded places, and indeed also with the, even after you've been vaccinated, and if you don't have symptoms, but the twice weekly testing as well. And it's actually these combination of measures together which provides us the safest path through the winter ahead. Thanks.
Thank you, Jonathan. So yes, keep encouraging everybody, get out there, get your vaccine, and keep yourself safe. It's one of those things that when you look at the things that we've achieved in medicine over the last 100 years, the last disease, the last thing we ever actually eradicated was smallpox, and that was back in 1980. We haven't eradicated the disease since then. We've nearly got rid of polio. It's still in 2 or 3 countries. But we're very poor, despite the brilliant technology that puts people into space, puts spacecrafts on Mars. We haven't been brilliant at eradicating disease. However, if we're going to come close to eradicating one, it looks like it could be the HPV vaccine against cervical cancer. If you look at item number 8, our success rate since we've introduced this back in 2008, vaccinating 12 to 13-year-old girls has shown that there's been a 90% reduction. And we've only been doing this for 8 years. Imagine what it'll be like when we're doing it for 10 or 15 years. And then the second thing is that last September we introduced that to vaccinating boys as well as girls. And it's been a real success program in reducing the incidence of cervical cancers, reducing the deaths, etc. And we're in the infancy in terms of elimination of a disease at 8 years. So I'm very optimistic about that, and that one day cervical cancer might be quite a rare illness. So that's item number 8 on the HPV vaccination, and it's going really good. And as I say, we're now vaccinating boys and girls. If we look onwards down, the next item, I think, which caught my imagination was spiking. So we had something at item number 14 and a joint effort to address spiking. Spiking defined as adding alcohol or drugs to somebody's drinks or somebody's person. I suppose it's been around for many years. It's if somebody was drinking a Coke and you put a vodka into it, that's effectively spiking. We're more familiar with the use of things like Rohypnol, which is the date rape drug, and GBH as another drug that's commonly used. But it became frightening in the last number of months in that people thought of spiking as sticking a needle into somebody and injecting them with something. And that's the thing that we've been made aware of more recently. Within 72 hours, we encourage them to go to the casualty department where they'll be given an immunoglobulin to protect them against disease, and they'll have bloods taken and they'll be started on the hepatitis B regime, etc. After 72 hours, they come to us in general practice, and they've missed the opportunity to get immunoglobulin, but we start them on hepatitis and take their bloods and then recheck them for HIV and hepatitis and all that sort of stuff. So it became very much a front page of the tabloids because of the idea that you could have a needle stuck in you and have something injected into you. But spiking in itself with drugs and alcohol has probably been around for as long as we can remember. So that's one of those that caught our imagination. It has been sent out, and every GP is aware of what their role is. Every casualty department is aware of what their role is, and we're just prompting people to come forward and get treatment. And people will often say, how could you be stuck with a needle and not know about it? If you've been out and you've had a few drinks and you bang your head, you often wake up in the morning with your bruise, but you don't know what you actually banged into. And I remember when I was a casualty doctor, the most dangerous person that you could ever send home was the drunk, because you could never be sure what injury they'd sustained before they got to casualty, and they always underestimated the severity of the injury, particularly head injuries. So you could send them home and they'd have a hematoma and they'd be dead the next morning. So yes, you could be stuck with a needle in a club with a few drinks, and you wouldn't know about it till the next day. Councillor Martin.
Yeah, thank you, Chair. It's a shame that there's nobody here from the Police Crime Commissioner's office, because obviously we need to enforce the regulation on nightclubs more, to be more stringent about how they're letting people in, because that's where it's really happening. My daughter's a university student, and I know that that's where it's more prevalent, in the nightclubs. So it's the Nottingham University students who were being mainly the victims of it. And
Yes.
I think there must be some more stringent measures on how they allow people into these clubs. I know it's easy for me to sit here and say that, but they own the clubs and they make a lot of money from the people that come into them. And I think the police should be enforcing the regime on that.
Yes, a point well made, Councillor Martin, and we do invite the police and crime to come along, and we do have apologies for them today, but absolutely typical of an item where, from a safeguarding point of view, it would have been interesting to have an update on what they're doing. I remember last time I met Caroline Henry, she was about to go out on an evening with plainclothes officers and dogs to patrol around where the clubs were to see if they could pick up on any of these drugs. So they were actually being proactive on the street. So I know that the Police and Crime Office are actually been actively involved in upping their detection of this. Excellent. Again, I was starting to flag on the 89 various points, but I'll bring up point 52, which is social prescribing, and it was just shown how social prescribing is being embedded into nuts. But it's not just been embedded into nuts, it's been embedded into all of the primary care networks, all 20 of them over the whole of Nottinghamshire. Social prescribing is, as we know, a non-medical intervention in order to improve the health and well-being of people that doesn't involve the doctor, doesn't involve drugs, but merely involves creating an environment, creating a diversion, creating an interest that actually allows people who may be depressed, may be lonely, may be isolated, may have complex disorders to have a way of actually being brought away from those and brought out of the environment into an area that they are happier and feel sufficiently distracted. Distraction is the greatest single painkiller ever invented. Now, so did anybody find anything else there that they would like to talk about? Councillor Martin?
Picking up on this item 30, because obviously we've got
Sorry, picking up on what, Councillor Martin?
item 30 in your
3-0.
Yeah, I think it's quite relevant because it touches on agenda item 6 when you get to it. And I think it's quite good, and it's again something that the council has probably been pretty good at doing and formulating, but not being able to get the message out there. And you've got 60 odd councillors, and I think you should use that forum and get it out there, because I've just been sharing it around in Southstone and Mansfield and Kirkby and Hucknall, because it's a really good programme, you know, and I think we need to just promote it, because that's what happened with the Not Help Yourself app. We actually had an officer come round and talk to our parish councils about it, you know, and promoting it is the main idea behind it, and that's going to help in the reduction of suicide.
Yeah, a bit like Cooth, the online counselling service that we have for young people in Nottingham, and we can't get away from the fact that the youth of today are an online generation. I was speaking yesterday at Health Scrutiny about getting information out to patients and about the Nottinghamshire app, and as a practice we are the #1 practice in Nottingham, but we're at 37%, and that's with bringing people out to educate the patients on getting onto it, trying to deliver that to people at 37%. Other practices down in the single digits. So it does appear to be something that should be quite easy to do, but is quite a challenge, isn't it, Councillor Martin? Jonathan, did you want to say anything?
Just to add, well, and thank you for the suggestion. So from memory, the website was set up just a couple of months ago, but it's actually only being launched this month. And I think you're quite right. As part of that launch, it would be great if we make sure that our comms colleagues work with councillors to get that promoted really well across the county. Thank you for the suggestion.
Thank you, Jonathan. You can, Sheila. Microphone.
Do you get any information from Bassetlaw? Because you've got Gedlin and everywhere, but I don't see Bassetlaw with any.
Can I go over to Bryony, who compiles the list? Thank you.
Hi, Councillor Place. So what happens is I send an open invitation for anybody to submit reports or updates for the Chair's consideration and the Board's consideration. And Bassetlaw do usually submit some articles, so I'll follow up with them and make sure there's an inclusion for January's Board meeting.
Thank you, Councillor Place. You've guaranteed that we'll cross the 100 mark for the next meeting. Remind me to thank you. So we're going to move on then. That's the Chair's report, and we're going to move on to item number 5, which is the approval of the Better Care Fund. The Better Care Fund being from the 1st of April 2021 to the 31st of March 2022. That is the financial year that we are approving for the Better Care Fund. The Better Care Fund has been around for an awful long time, and it was really the forerunner of the ICB, or the Integrated Care Board. It was the amalgamation of monies from the CCG and monies from local authorities combined to do combined projects to improve the health and well-being of people and truly integrate care. So this was like a vanguard, and I think we all thought it would expand to become bigger and bigger and bigger and become the ICB, but the ICB came and took its place. So it started back in 2013 to something like £3 billion worth of money under Section 75 approvals, doing a combined amount of projects that include supporting discharges, disability grants, etc. So it's been on the go for a good 9 years. And this is approval. It's a statutory requirement that it gets approved through the Health and Wellbeing Board. And we're going to pass over to Claire Gilbert. Where are you,
Hi
Claire?
there. Hi, I'm on the screen,
No wonder I
hopefully.
couldn't see you, Claire.
Hello there.
Go ahead, Claire.
Yeah, thanks very much, Councillor Doddy. As you say, this is, the fund obviously is intended to support integration, and but we've ended up almost having the BCF and the sort of separate track around the ICS and now the Integrated Care Board. There is, to give a bit of reassurance, there is a piece of work that is ongoing about where we're obviously looking at opportunities for a more joined up approach to commissioning across the ICS, and alongside that we are reviewing the Better Care Fund and the lines within it that will support better to support as sort of integrated approaches around sort of key areas such as mental health, for instance. But that piece of work has not yet sort of come to fruition, but it's in place, and it's sort of timetabled throughout the coming year for us to work that up. In terms of what I'm bringing here today, it's a report to say that a report's coming. So we didn't have any reporting, really, sort of formal reporting out the BCF last year because of COVID. This year, we very latterly, we were in September, we were asked to produce a plan for this year, for in year. So, and that had to be submitted this month. Unfortunately, because of the timelines of coming to the Health and Wellbeing Board and getting that submission in, we weren't in a position to sort of be able to share with you the final version of that submission. So that's going to be coming to the board in January. But it's really to already notify you of that fact, and to as Councillor Doddy has identified, this is part of our formal sign-off process to around the BCF, and obviously the sort of key execs across the CCGs, both in Bassett Law and the city and county, along with the local authority, have sort of signed off the report, and it will come to you with a little bit more detail in January. We had an opportunity to do a narrative, which we have added in, looking at some of the areas where we are working jointly, and again we will reflect that more in the sort of January discussion. So this is really just to say it's been submitted. We're going to get retrospective approval in January, hopefully from yourselves, and the key people have been involved. So it's sort of a formal part of the process at this stage, and I think it might be useful further down through the year perhaps to come back to the Health and Wellbeing Board about thinking about how we are taking this through in terms of aligning that to the Integrated Care Board work, and what the opportunities that presents us with.
Yeah, thank you very much, Claire. I mean, it's a reasonably predetermined sort of ring-fenced sum, which is sort of allocated pretty well in its entirety. Did COVID have any impact on the spending, on the allocation, or did everything remain as was?
Because effectively, as you say, it's almost now becoming the baseline funding both for the CCG and for the local authority. So from that perspective, there wasn't really any shift in funding. What's happened is obviously a lot of this work is about supporting hospital discharge, and so there have been the additional sort of government funds that have supported that discharge process, and we are continuing to work as a whole system, and again that's including our city colleagues, around the discharge to assess process, and we're doing, looking at what that financial package needs to look like, and as part of that work we're linking back into the BCF and saying which bits of that are funded through BCF work. But yeah, so there was a huge and additional injection of cash that we've had that will end in March of this year to support those D2A processes, and we're then looking at what that means in terms of our longer term needs around that agenda to meet meet some of the many current pressures that we're dealing with in terms of the blocks that we've got around discharge and the difficulties we've got around the workforce. So there is a lot of collective work happening across the system to try and address that.
Thank you, Claire. Does anybody have any questions for Claire? I've got Councillor Walters.
Yeah, thank you, Chair. I'm just, as usual, a little confused with some of the terminology. Paragraph 1 and paragraphs, bear with me a second, 8. So has this plan actually been submitted on the 16th of November?
So yes, yes, it has. We had a bit of a discussion about sort of whether it came because obviously we have to submit the papers before we had the report. So this is a sort of a plan, proposal to sort of say we'll be bringing forward the formal report next time. But unfortunately, we didn't have we have to go to the kind of relevant people to get the sign off, which is sort of listed in paragraph 8. But we did discuss whether we just brought very latterly the plan as it has been sort of submitted already, or whether we sort of allowed it to come to January, and that was a decision that was made.
So with the retrospective approval to be sought from the Health and Wellbeing Board at its next meeting, etc., etc. So we can still chisel away at this, so do I take it? If we have any points we disagree with or wish to discuss, or is it done? Is it, it's set in concrete and we can't do a thing about it? So.
It is, to be honest, pretty much set in concrete. It's a fairly open kind of narrative. It doesn't pin us, at the moment. It effectively commits us to continuing as we are. It explores sort of some of the new ways in which we need to monitor and measure the system. As I say, I think the opportunities will be going forward about how we re-look at the plan again. We haven't had, because the planning for this came so late in the year, that we weren't able to sort of unpick any of that. I think what we want to do is to begin to think, how over the coming months that we reshape our BCF fund to make it much more meaningful. And then I think at that point, that to have the right engagement with yourself at that point will be a more meaningful part of that discussion.
Thank you, Claire. Was there, Councillor Walters, a particular area where the money was allocated that you had a particular challenge on, or one that you had an area in, an interest in, that you thought, be it delayed transfers of care, early discharge, disability grants, etc.? Was there an area you were particularly interested in?
Not necessarily, just the general terminology
just a general
of
thing.
approval,
Yeah.
as opposed to acknowledgement or whatever.
Yes.
It seems to me, it's all set in concrete, just rubber stamp this and away you go.
Yes. I suppose largely because most of it's predetermined. So, yes, and it's already allocated. Thank you, Councillor Walters. Thank you indeed, Claire. And I moved that we moved recommendations on page 31. Can I have a seconder, please?
I'll second the recommendation.
All
Chairman.
those in favour? Moved. Thank you.
Thank you very much.
Thank you, Claire.
Thank you, Chair.
Fantastic. So I'm going to move on now to item number 6. And item number 6 is suicide prevention in Nottinghamshire. To look at our prevention strategy and how we can potentially intervene in terms of suicide, bearing in mind there's probably over 5,000+ suicides in England every year. Just to cut my attention before we go over to Robin, is item 5, which is the list of occupations, groups most at risk, and the first one in there is doctors. Thanks very much. You could have buried that a little bit further into the information. And I always remember when I was looking at things like that, publicans were always on the list because they were one of the top people, but there's no publicans written down here. So yes, suicides 5,000+ per year in England. Can I pass over to Dr. Robin Wright for the paper?
Thank you, Councillor Doddy. So in Nottinghamshire County, we lost 188 people to suicide in the last 3 years. Suicide has a significant, lasting, and often devastating impact on individuals, friends, families, and the wider community. However, suicide is preventable, and we aim to reduce the rate of suicide by proactively improving population mental health and well-being, and by responding to known risk for suicide. Next slide, please. Today, we're going to give an update on the progress for the suicide prevention approach in Nottinghamshire County. We're seeking support for suicide prevention activities and seeking approval for the Suicide Prevention Action Plan refresh. As Councillor Lodgy was saying, we know that certain groups are more at risk of suicide, and this includes men, people in contact with mental health services, those at risk of self-harm, and those in contact with the criminal justice system, among others. And we know there's a strong link with deprivation, with those living the most deprived circumstances at higher risk. Next slide, please. So if you could turn your attention to the graph on the slide, which is also included in the paper. We're going to use this to discuss the latest suicide rates for Nottinghamshire and the districts. So this graph shows the suicide rates per 100,000 people in Nottinghamshire over the last 10 years. The y-axis shows suicide rates per 100,000, and the horizontal x-axis shows the time periods. So it's over 10 years, but we measure suicide rates as 3-year rolling averages, which takes into account small numbers and allows a greater degree of comparison between years. We're going to start by discussing Nottinghamshire County as a whole. So towards the middle of the graph, there's a dotted line, which represents Nottinghamshire County. And as you can see, the suicide rates in Nottinghamshire as a whole have remained stable over the last 10 years. However, more recently, we have seen a reduction in our latest data for suicide rates in Nottinghamshire, and that's a reduction from 9.1 to 8.6, which is below the England average, which during this time actually slightly increased from 10.1 to 10.4. And this reduction in deaths in Nottinghamshire, in terms of numbers of people, this was equivalent to reduction in deaths from 199 to 188. Also on the graph, the other lines represent different districts and boroughs across Nottinghamshire. And as you can see, there is some variation, and this can be partially explained by the small numbers when we're getting down towards individual districts. However, as you can see, towards the top of the graph, Bassetlaw does have a higher suicide rate consistently. This is similar to neighbouring districts in South Yorkshire, such as Doncaster and Rotherham. And in response to this higher suicide rate, Bassetlaw received extra earlier suicide prevention funding. Next slide, please. So to talk more about our suicide prevention activity, our work is led by the Suicide Prevention Strategic Steering Group, which provides leadership for the suicide prevention activities, and this feeds into the Integrated Care System, Mental Health Board, and the Nottinghamshire Health and Wellbeing Board. And we recently revised our terms of reference to ensure a clear strategic and governance focus. This work is also supported by the Suicide Prevention Stakeholder Network. This is a forum to engage, work with, and support a wide range of stakeholders to implement suicide prevention activities. It enables sharing of good practice, cross-organisational collaboration, and partnership working together to improve outcomes of the population and reduce suicide rates. There are various funding routes for suicide prevention work, and some of this funding goes towards a 24/7 mental health crisis line, Nottinghamshire crisis sanctuaries, and Postvention bereavement support, so support to support people recently bereaved by suicide. Next slide, please. So we received new Wave 4 funding. This was an NHS England funding to support our suicide prevention activities, and our programme of activity around this is divided into 4 themes, as shown on the slide, and I'll talk through those now. So for competency, compassion, knowledge and skills, we provide training for a range of audiences, including training that's free to access for voluntary and community sector. And we're in the process of commissioning a mental health and suicide awareness training needs assessment. So this is looking at training needs across the system and in communities. And based on the findings of this training needs assessment, further training will be developed and delivered. For communications and public awareness, we've developed new materials, including materials that are targeted at students and older adults. We're in the process of developing a recognisable brand and campaign. This is with a co-production approach, so involving service users, people with lived experience, and service providers, working together to produce effective materials. We continue to promote awareness days, such as World Suicide Prevention Day, which was on the 10th of September. And this year we delivered a social media campaign across Nottinghamshire County Council social media channels. And this provided information on key support services, training and further information. And this reached over 489,000 people. For prevention support for high-risk groups, we've set up the Further Education and the Higher Education Suicide Prevention Network. We're in the process of developing the small grants process, which provides funds for small-scale but high-impact projects for suicide prevention in communities. And finally, for real-time surveillance. So we have a real-time surveillance system in place, which potential suicide deaths can be reported into this system in real time, which allows quick identification of potential deaths, as well as any cases that may be linked, and identifies any changes in trends so we can inform our local suicide prevention response. And we have a multi-agency real-time surveillance group who regularly meets. Next slide, please. So moving on to the Suicide Prevention Action Plan refresh, the board will have seen in Appendix 1 our updated Suicide Prevention Action Plan. The refresh has been informed by a progress review against the current plan, in addition with a review of recently published documents and reports on suicide prevention at both local and national levels. This includes actions around governance and equality, real-time surveillance, service delivery and populations. And this includes work targeted at key groups, including veterans and people with autism. Next slide, please. So to summarise, we aim to reduce the rate of suicide in Nottinghamshire through a preventative approach by proactively improving population mental health and wellbeing and by responding to known risk for suicide. And we ask the Health and Wellbeing Board to identify a named mental health champion within each organisation who can assist with coordinating engagement with the suicide prevention stakeholder network, facilitate participation in the mental health and suicide prevention training needs assessment, and support embedding the suicide prevention activities outlined in the report across the system, and to endorse the Suicide Prevention Action Plan refresh for 2021. Next slide, please. So we're happy to take any questions, and Catherine Pritchard will be taking questions. Thank you.
Thank you, Robin. Very, very comprehensive. Fits in very well with the workshop we did on mental health not very long ago, where we brought forward mental health concordat and championed the need for a mental health lead in organisations and mental health first aiders, in the same way as you would have ordinary first aiders who recognise people in the office who might have a degree of distress, etc. So it shows that the sort of co-production and overlap of a variety of areas. In terms of the sort of detail, Bassett Law just jumps out at you. It shouldn't be any worse than Ashfield, really, when you look at it, and yet historically it has been. Rushcliffe probably doesn't surprise you as the lower numbers that are there. Is there anything that is specific to Bassett Law that could be addressed in health inequalities, etc., that we're aware of? But you can hold those, and I'll throw it open to anyone else who wants to ask questions. Maybe you can take them together. Sheila, thank you.
Is there any chance we can hear what happened in Mansfield? Because they've gone really, it weren't high at first, but it's gone down.
Okay, so we'll add in Mansfield and Bassett Law. Okay, any other questions? Councillor Martin.
Just more observations, really. I mean, I think, like you say, Bassett Law, and actually it's that Newark and Sherwood there on the rise. There's something demographically amiss there. Is that because they were in a different clinical commissioning group area, or is that just how it is nationally? You know, there are a lot of new actions in the action plan, and I think that can only be welcomed, really.
Yes.
You know, and I think the Suicide Prevention Day promotion is a really good thing because it makes people aware. And I think as part of that, you probably ought to have some short clips of victims. So when I say victims, I mean people who have survived, people who have died, a video on the effects of what losing a parent has had on them. Because I've got two nephews and a niece who lost their dad when he was 38, and the impact on their lives is tremendous. And a video from willing people who have lived on after as a result of somebody dying by suicide would be quite good, because it would impact on people more, because it would give you they're not survivors, they are family members who are survivors, really, you know, and it would probably give a good visual account for other people who might be thinking about it, because I think it has an impact on other relatives who may have an inclination to do that, you know, and I don't know why Bassett Law and Newark and Sherwood are in that higher echelon. I don't, because, you know, I mean, when you look at the graph going across from 2010, it's sort of fluctuated up on a mean average, and it's been like that since 2004, believe it or not. But you know, it's, I welcome all the actions in the report. I think there can only be anything that takes the pressure off doctors, because we've had this conversation before where somebody who's suffering mental health issues like that comes into a doctor and they've only got 15 minutes. It's just impossible for them to deal with it, you know. And we talked yesterday to Bassett Law Teaching Hospital, who are creating an emergency department village, and we talked to them because the mental health services in Bassett Law are being moved to Mansfield, and as part of their emergency village that they've just got 17.5 million for, we talked about not transferring children to Doncaster Hospital and Sheffield hospitals unless it was absolutely necessary, because some of those children come in with mental health issues, and they're dealing with children up to the age of 18 in their assessment unit. So I said to them yesterday, as part of your reconfiguration for the internal Bassett Law Hospital, do you think when you close your psychiatric ward down and your assessment unit and you build your new emergency village, could you have some isolated areas in that hospital for people who have 24-hour to 48-hour mental breakdown? Because that is the crucial time. That's when, because it's like talking to a wall when somebody commits suicide. You can talk to them, and you can talk to them, and then the next day, or even an hour later, they're still in exactly the same mindset. And that's, so when you get to that crucial point, that's when they need the help the most. So the more facilities we've got, especially looking at Bassett Law's graph, it would be a very important thing that I would be pushing for in Bassett Law Hospital.
Thank you, Councillor Martin. I think when you said 15 minutes for a GP appointment, it's only 10 minutes. Yes, it's even worse than you thought. I'm going to say that from the 1st of April next year, that general practices in primary care networks have got funding for a mental health social worker in all of the 20 primary care networks as the first one and the first time to be based within GP surgeries specifically to deal with mental health. And I had a presentation from one of them last Wednesday who's coming specifically to my area. They have a direct connection to Nottinghamshire Healthcare Trust, and they're seconded to the primary care networks. So they have a direct line to the crisis team, they have a direct line to the psychiatrist and a direct line to the GPs, and it's a really exciting development in Nottingham, and they're already starting, but the funding and the approval was from now, and every primary care network would have one, which is really positive. It's an interesting one when I look at all those figures as well, and Bassett Law, and I'm thrown back to something which is quite unique in the world, really, and it's known as the Glasgow Effect. If you go to Glasgow, you have a part of Glasgow where people die in their mid-40s to 50s, and as you walk down the road through each bit of an area, people live a year longer and a year longer, till in one area they're living into their 90s, and people have racked their brains for years to figure out what is this unique system that exists in one city in the UK that's not replicated anywhere else in the world. And they thought it was that an awful lot of people with an awful lot of complex morbidities, a lot of drug addictions, a lot of alcoholism, a lot of elderly related problems were rehoused in one area within one particular period of time, and that it had that sort of effect as it went on. But there may be some sort of long-standing Glasgow effect at work, and that's the only thing I can think of. Jonathan, can I go over to you?
I'm just wondering, on reflection, Chair, if you're happy with it, I'll let Kath and Robin pick up the questions that were raised, and if there's still something to add, perhaps I could come in. Thank you.
Thank you for your questions and your interest in this paper.
Yeah.
It's obviously a devastating situation for those of us who have been bereaved by suicide. So we do need to acknowledge that, but we do need to talk about suicide. It's the most important thing we can do, to reach out and talk about suicide. So if I could say that to start with, and then I'll come back to Councillor Martin's questions in turn. You ask about data, and it is a difficult one, because whilst every loss is very significant to individuals, what happens with the relatively small numbers of deaths when we break down to district and borough level is what we see as fluctuations that take place over time. And the reason why Robin put that graph in your paper with that middle line in relation to Nottinghamshire was to show overall what happens. But we do know those people at risk. So we know that people who live in deprived areas are more at risk of suicide. So we know that, and as Robin's indicated, particularly men are at increased risk as well. So there's variation in relation to small numbers. Can I focus on Bassett Law to start with? So in relation to Bassett Law, there has been a recognition nationally in relation to that higher rate that you've seen. And as Robin mentions, those rates are similar to what they see in the South Yorkshire area as a whole. And in order to try and work on that, Bassett Law were provided with National Health Service England funding a number of years ago now to help do the preventative work that you say today in our paper for the whole of Nottinghamshire. So they have had initial funding around that. And in advance of this meeting, we asked questions around sort of the work that Bassett Law have done. And to give you a flavour of it, they've funded self-harm and suicide prevention workshops. They've had a small grants process to develop grassroots support. So those small local organisations that reach out to individuals that may not articulate that they're at risk of suicide, but are so important in bringing people together. And I know that sense has been lost for many of us over the past year and a half, almost 2 years now. They have specific projects related to men who we know are most at risk. So there's a project called Men on the Edge, Men's Walk and Talk, and they've linked to football clubs to try and reach out into that organisation, as well as a veteran support officer. And that's one thing from a county point of view that we're really keen on developing going forward. The other thing that Robin mentioned, which, again, if I can reiterate and highlight, one thing that we've done across the system is introduce what they call Postvention bereavement support. So this is specialised support for those people who have been bereaved by suicide. And if I can explain how that works, when the police attend, the police are able to directly refer families, friends, even their own colleagues, into bereavement support services that are offered. And so we have those services available now, which I think are crucially important. Every anniversary is an important anniversary for those people who have lost from suicide. So I hope that addresses some of your questions. Councillor Martin, if I've missed anything, then please let me know.
Robin, did you want to add anything to that?
I don't have anything to add.
Jonathan?
So there's just one thing to add from my perspective, and thank you for the report and presentation that you shared with us. Noting that the work very much depends on the engagement of partners with that network.
Yes.
And the importance and the contribution that board members and their organisations can make to this, and also noting that there are a number of people who are unable to make the meeting today. I was wondering, Chair, with your agreement, whether we might write out to board members, including those who weren't able to make today's meeting,
Yes.
to underline how it is that they can feed in to us, the person with whom we can work in their organisations. It would be a real shame on the back of this if we were to lose momentum. We want to be able to follow through now, but that's really going to take the contribution of all partners. Thanks.
Yep, absolutely. We're all happy with that? Yep. So, Councillor Tideswell.
Thank you, Chair. Does County Council have like a two-way communication relationship between local businesses, companies and unions? I know unions have been highlighting this area quite a lot. Broxton Joint Consultative Committee, we're always having rapport with them on several subjects, and this did actually arise a couple of months ago. And does County Council have the same arrangement?
I suppose that there's a significant number of partners signed up to the Mental Health Concordat that we're aware of directly, who've agreed to the principles embedded within that Concordat. And it was a refresh of the Concordat that we did most recently of an existing set of relationships which we've reinforced since the last workshop. Go ahead.
Thank you for that suggestion. I think it's a really interesting one in relation to reaching out to employers. I have to say I'm not sure about that formal mechanism internally, but I'll certainly look into that. So I imagine there is one, but personally I'm not sure what that is.
Councillor Place.
Can I say from personal experience, when we saw a doctor, we got over half an hour.
You got a what?
Over half an hour.
Yes.
She spent a lot of time with my grandson on his own.
Yes.
And she was really good. And also about Bassetlaw going to Mansfield. A lot of people in Bassetlaw have objected because we're closer to Doncaster and it's on a bus route. You know, it's getting people to where they're needed, isn't it? And family to be able to visit. It's just that things.
The change to Bassetlaw doesn't stop people using services of South Yorkshire. It just means that the services are paid for by Nottinghamshire.
Yeah.
And I've got patients on the border and they go over to Derbyshire all the time and you just accept the responsibility for that cross-border which exists in every county in England, so they're still able to utilise a lot of those services. I'm going to just go to Jonathan first.
Thank you. And it was just to engage with Councillor Tideswell's comments a moment or two ago, and I think we could perhaps, as part of this, pick up an action, because my past experience tells me that it's often our districts and boroughs who have best links with employers in their local patch. It probably underlines the other action, the importance of making sure that we've got a really good representative
Yes.
to link up with in each of the Health and Wellbeing Board partner organisations,
Yes.
so we can follow through on that, Kath. Thanks.
Councillor Martin.
If I can just pick up on Councillor Place's points about Bassetlaw Hospital. The psychiatric ward is not fit for purpose. It's been there a long time and they want to reconfigure it. So that it was, they moved because a lot of people who go to Bassetlaw Psychiatric Ward come from Baseford, Arnold, Gedlin, Ashfield, and there are actually very few people that come from Bassetlaw that need long-term mental care. So that's where they move into, I can't remember the name of the hospital, it's in the middle of Mansfield. And now with this emergency village that they've just got 17.5 million for, that will cover mental health issues for people up to the age of 25. So it's people who need psychiatric care for 24 to 48 hours in the initial that they need to re-cater for. They're the people that would be most at risk because they'd have to go to Kingsmill or to this new hospital. So that's what it is. So they are narrowing it down. They've got a progressional plan and it's quite good actually. So we made them acutely aware that that's the gap yesterday.
Yet the acute beds needed by the crisis intervention team for short-term emergency care. Excellent. Does anybody else have anything further to add to that? If not, I'm going to thank everybody for the discussion and I'm going to move the recommendations contained within the paper on page 40. Can I have somebody to second that?
I'll second that, Chairman.
All those in favour? Thank you. I'm going to move now to item 7 again one of those areas which was highlighted over the COVID lockdowns, etc., where many people were trapped in houses, and COVID and the restrictions of movement almost gave people a license to intervene in other people's lives. This item is about improving the outcomes for the survivors of domestic abuse. And the first thing always with domestic abuse is to remove the person to a place of safety. But obviously putting a mother and a child, whatever, into a place of safety is not a long-term strategy, and it's not a great place to give a child the best start in life. Improving the outcomes for the survivors of domestic abuse. Rebecca.
Thank you. So I welcome the opportunity today, hopefully people can hear me. I welcome the opportunity today to speak to you all about and give you an update on the developments in the domestic abuse agenda. There's been a few developments over the last year, and these have included the Domestic Abuse Act receiving royal assent through Parliament in April 2021, which provided the authority with some additional statutory duties regarding domestic abuse. That has also resulted in some additional governance arrangements and the development of the local partnership board. But before I go into the details on those, I think it's important that I do emphasise that it has been a difficult year for domestic abuse survivors, and there has been a number of partnership approaches delivered during this time to ensure that the support has been available throughout the last year. That has included extra money going into the helpline and extra money being put into our domestic abuse support services, and also extra money going into the housing approaches so that as many people as possible could be provided with safe accommodation when required. So to move on to the Domestic Abuse Act, we've received 1.54 million additional funding this year to deliver safe accommodation for domestic abuse survivors. That includes children and men and women survivors. The districts and borough councils have also received funding of £223,000, and that is to help support the authority, the county council, to deliver this agenda. We recognise that domestic abuse services and the leadership of the commissioning approach cannot be delivered by the county council alone. So we work in partnership both with district and borough councils and also with the Police and Crime Commissioner's Office to ensure there's a joined up approach to how we are delivering services across the county council. And one of the ways that we're looking to do this is through the domestic abuse strategy, and we're looking to develop a joined up vision, which is for Nottinghamshire County Council to drive strategic change through partnerships and leadership to make Nottinghamshire a place where survivors of domestic abuse receive the support they need to feel safe and rebuild their lives. Perpetrators are held to account for their actions by the police and the criminal justice system and wider services, and that communities recognise and respond to domestic abuse early to prevent abuse from happening and support survivors and their families. As we've received extra funding, what we've completed is a robust piece of work looking at needs assessment to identify what outstanding needs there are within our communities. We did that in partnership with the domestic abuse sector, but also our partners in the district and borough councils, within the health services. And we looked to ensure that the commissioning plan that is attached within the Appendix 1 would be a complete piece of work to help to move forwards, to help us to reach our vision and aims. We have identified there are a number of areas where we still require extra information on the needs of survivors. So we are doing a number of deep dives which relate to some of the points that have already been highlighted today. So one of the deep dives is on male survivors to identify what are their accommodation needs. Another deep dive is on female survivors with additional protected characteristics, which includes disability, sexuality, and also considers how we can make sure safe accommodation options work for them. So it may be that what we have in place currently is not always right for them. So we're doing an extra piece of work to look into that. And then we're doing an extra piece of work as well, a deep dive on mental health, because what we find, and as we've spoken about already today, is that people who are in a domestic abusive relationship and come out of a domestic abusive relationship will have mental health issues that relate to that, and it will have an effect upon their lives for a long time. So we're looking at how we can tie those things together and build better services. So what we have here today is an example of the strategic approach, the local partnership board developments, and we also have the strategy as well. So you have the strategy as Appendix 2, and then there's the terms of reference to the local partnership board. And I welcome any questions.
Thanks, Rebecca. I'll open that to questions. Remind people that domestic abuse is not just physical, although you think of it as being physical. It could be emotional, perhaps financial, where you just don't give anybody any money, so they can't buy any clothes, or they can't leave the house, or they can't go anywhere. Could be restricting access to the children, emotional, etc. So it's a wide spectrum, and often very subtle in its nature. Thank you for outlining that programme, Rebecca. And if there are no other Councillor, please.
Can I say I'm glad that you've mentioned that men are getting support as well, because sometimes they're forgotten, aren't they? And they're as much at risk as a woman at the end of the day. Nobody wants the children to be upset, man or woman, as far as I know.
Thank you, Sheila. Councillor Martin.
Yeah, just wanted to highlight the fact that some of the national institutions are exacerbators in the breakdown of relationships, because they take so long to sort stuff out. So, you know, when people get divorced and they've got kids separation and they're relying on the Department to work on pensions and universal credit and stuff like that, are we incorporating in the plan some kind of fast track system where, if people are struggling in that respect, because not everybody can deal with that when they've got emotion, all that emotion going on, you know, and I think that would help equally blokes just as much as women when they find out, you know, that child's not theirs or whatever, you know, because that's another thing, because you get what used to be the, I don't know what they called it, the CSA, I think it was, you know, chasing males for money for children that aren't theirs, and that process is a complicated process to get round into it. So I just wondered if in part of the plan, I mean, I have read it, but I just didn't pick it up, you know, if there's help for people struggling with, you know, universal credit and stuff like that, and CSA. Is it called CSA anymore?
Rebecca, I can only imagine that it's a multiple level intervention, that we don't just put people in accommodation and leave it.
No, so what we do is we have domestic abuse support services that surround the survivor and their children, and those offers around accommodation will be related to their need. So some people do not leave the accommodation and go to refuge. As people think about safe accommodation, they normally think about refuge provision. So a house where a number of women and children may live safely away from their previous perpetrator. We also look to make their own accommodation safe so that they can stay within their own homes. But I think the conversation that you're talking about those wider implications of domestic abuse and how that fits with the wider system and the unintended consequences there may be both to the survivor and also some of those considerations for, in some cases, perpetrators. I think they're the kind of conversations that we will be looking to have as part of the local partnership board. So within the strategy, we focus the first part of the strategy on safe accommodation, but what we haven't done to date is we've not completed the strategy in its entirety. And the reason for that is that domestic abuse is incredibly complex, and we've recognised that we need to do work on each chapter, each element of the strategy to develop a full and complete picture of domestic abuse and how we can respond to domestic abuse across the whole of the county. And that includes considering the perpetrators. How do we hold perpetrators to account? How do we develop our perpetrator prevention programmes, which are being led by the OPCC at the moment. But we also need to consider the needs of children and young people, the role of health services, the role of the criminal justice system, and also the needs of high-risk survivors. So we've listed those, and we're going to be focusing on each chapter and then bringing those together and reporting those through the local partnership board, which should hopefully address some of your points.
Thanks very much. Got Councillor Walters.
Thank you, Chair. Just a bit of a question. I've noticed on page 69 of 108 that unfortunately Ashfield is top of the list on domestic abuse. Is there, that was in what, 2018. Have we got any more update details on that, please? And just out of the top of my head, is there any breakdown in Ashfield, for example, of which ward has the most cases or reported cases of domestic abuse? Is there such a definition of that, so we could really drill down on it? Thank you.
Thank you, Councillor Walters. Rebecca.
Thank you. We do have some more up-to-date information, and I can share a supplement after the meeting on that. We don't tend to drill down to details around each ward at this level, but we do share information with our community safety partnerships so that they're aware of what the needs are at a local level. And the reason we don't share it too widely is because obviously we're talking about people and their lives, and people can become identifiable if we start to share it too widely. But you do mention around the challenges in Ashfield. Those challenges are still there. We find that there are three areas that stand out with the domestic abuse rates, and that's Mansfield, Ashfield and Bassetlaw.
Just a final point on this, where you've shown the estimated, I can't quite read it, numbers or occurrences, is that per capita or is that just overall reported cases? Just to try and get an idea of how we stand with the rest of the county. I'm looking at 69 of 108. I don't know if that's...
Oh, thank you very much. Apologies. So the information within here was information that was presented as part of our joint strategic needs assessment, and the information was related to the prevalence So it was information that was generated from information we had available from crime figures, etc. I can look into this in more detail and get you a further response if that would be helpful.
Well, I think per capita would give us a better idea of what's going on. Yeah, it could well be that the population in Ashfield is slightly higher than somewhere else, and so you're going to get a higher prevalence than of that. It's just an indication. If you could, please, that'd be great.
Thanks,
No
Councillor
problem.
Waters.
Thank you.
And the Joint Strategic Needs, I think, was 2019, so it was pre-COVID. So we have no idea what influence COVID had on it. Thank you all very much indeed. Thank you, Rebecca. I'm going to move that the recommendations are accepted on page 56 and formally get it seconded by Councillor Turner.
Yeah, I'll second that, Chairman.
All those in favour? Thank you. So I'm going to move now to item number 8, which is a sixth iteration of the local transformation plan for children and young people, particularly around their mental health. I certainly have noticed as a GP an increase in the presentation of children with mental health problems, an increase in the pressure of referral through to CAMS as a service, some of it due to backlog with COVID, some of it due to children struggling to reintegrate after COVID, depression, eating disorders on the rise, etc. So I'm very interested in this paper, and we're going to pass over to Rachel Clark.
Thank you, Chair. I think is there a slide for me to talk through first? Oh, thank you. That's just up there. Just before I start the presentation on the paper, my name's Rachel Clark. I'm Programme Lead for Children and Young People's Mental Health, and I sit within the Integrated Children's Commissioning Hub within Public Health in Nottinghamshire, and I work on behalf of Nottinghamshire and Bassett Law CCGs. We thought it would be useful just to give you an overview of some of the support that's out there for children and young people's mental health. The first is our Not Alone website, and you're going to be hearing much more about that from my colleague Orla, who's going to be joining us over Teams. And that's our newly launched website, which provides local mental health and advice for young people in Nottingham and Nottinghamshire. Another excellent resource is the Every Mind Matters, which is produced by the NHS. There's lots of excellent tips for self-care for young people, and also resources for parents in looking after their children and young people's mental health needs. For children and young people in crisis, we thought it would be useful to highlight our 24/7 crisis line, and it's the number to call if you're experiencing a mental health crisis and you need immediate help. And then to highlight finally another excellent national organisation, Papyrus, which provides Hopeline for children and young people who are having thoughts of suicide, or if you as a parent or a family member are concerned about a young person, you can contact this organisation for further advice and support. And then of course there's the 5 ways to wellbeing, reminding us of all the things that we can do to support our mental health and wellbeing on a daily basis. So, as I mentioned, I'll be starting off to talk you through the paper today, and then I'll be inviting my colleague Orla to come and talk around some more developments around school. So I'm here today to present the September 2021 Refreshed Local Transformation Plan for Children and Young People's Mental and Emotional Health. And it's part of some regular updates we will be giving the Mental Health and Wellbeing Board. And we're asking today that the board considers whether there are any actions they require in relation to issues contained within the report. And I hope the plan and the report that I've provided give you an overview of some of the challenges we do face in children and young people's mental health, but also of the wide-ranging programme of work that's going on. So just to give you some background, local areas led by clinical commissioning groups have been required to have a system-wide local transformation plan for children and young people's emotional and mental health since 2015. And now, whilst this is a CCG-led plan, it represents our system-wide ambitions around children and young people's mental health and covers the areas outlined in paragraph 4 of the report. So as well as focusing on our ambition to achieve NHS long-term plan targets, which relate to children and young people's mental health, suicide prevention and digitisation, it also reflects on the impact of COVID and the recovery and restoration plans. The plan has been endorsed by our Children and Young People's Mental Health Executive Group, the membership of which you can see in the paper, and the plan has also been supported by our refreshed JSNA chapter. Turning first to the impact then of COVID-19 on children and young people's mental health, the impact of this is still emerging. However, local providers are reporting an increase in referrals to mental health services and an increased level of children and young people presenting with more serious and complex needs. However, national data published on September 30th, 2021 indicates that following an increase in the number of children and young people with mental health issues identified in 2020, the situation now seems to be stabilising. Our local mental health services responded quickly to the COVID-19 crisis, and they adapted their service offers to include both telephone and online support. Providers have shared with us that some children, young people and families did not want to access telephone and virtual support. It just wasn't appropriate for us. As a result, during the recovery period, services have moved to providing a blended service model, offering both face-to-face and digital support. And during the pandemic, all services remained open to referrals and followed guidance issued by NHS England. We have had a recent provider collaborative review, which was undertaken by CQC in Nottingham and Nottinghamshire, and they identified that the system responded quickly at the beginning of the pandemic to adapt and strengthen existing pathways to ensure that children and young people with mental health needs continue to receive the right care at the right time. And that full report is now publicly available on the CQC website. Whilst COVID-19 has undoubtedly presented challenges in terms of service delivery, it's also expedited transformation. And as commissioners, we'll continue to work with providers to identify further opportunities and ensure that they're embedded into service delivery. But crucially, it'll be about enabling children, young people and families to have more choice about how and where support is received. Just to draw attention to some of what we think our key achievements are, we're carrying on our rollout of mental health support teams in schools, and funding has now been secured to extend coverage of mental health support teams to approximately 150 schools across all localities in Nottinghamshire by 24-25. We've created additional capacity for crisis home treatment and liaison services, and this has been secured. This will ensure 24/7 crisis intensive support will be available in the community and acute hospital settings, with the ultimate ambition that fewer children and young people will either find themselves in crisis, or if they do have the crisis, will have to go to hospital. The successful eating disorder successful eating disorder transition worker model has been replicated within adult community mental health teams, and we're also developing an avoidant restrictive food intake disorder pilot, which has been completed, and work is underway to develop a pathway to meet the needs of the children and young people with these presentations. As I mentioned earlier, children and young people's mental health providers have developed digital support, including video consultation, online self-management resources, and digitally enabled models of therapy. And finally, we know that a key part of COVID, not just COVID recovery, but providing good children and young people's mental health services is around engagement and co-production. And a wide range of this kind of activity has been undertaken with our MH2K citizen researchers in the last year, including around the impacts of COVID-19, improvements that we can make in our early intervention services, and also work on the Not Alone website. And at this stage, I'm going to hand over to Orla to talk to you more about the development of the Not Alone website and also the wider work of the Education Recovery Steering Group.
Thank you, Rachel. Hello, everybody. My name is Orla Green. I'm Senior Educational Psychologist at Nottinghamshire County Council. And I'm going to cross my fingers and hopefully on the screen in front of you, you should see the homepage of Not Alone. So Rachel, I might just double check you can definitely see that, where you guys are. Brilliant. So this is the Not Alone website, and it's been an absolute privilege to be the lead on this project as part of the wider Wellbeing for Education Return project in partnership with the City link, who's Dr. Maddy Papula, educational psychologist in the city. So to give you the wider context, Not Alone is phase 2 of the Wellbeing for Education Return project, which started mid-COVID with DFE funding for training to support schools in the return to school. And moving forward, we've used the phase 2 funding, which has been renewed this academic year, to support the development of Not Alone. So as Rachel has said, it is a website which provides local mental health advice and help for young people in Nottingham and Nottinghamshire all in one place. When we talk about co-production on Not Alone, we mean genuine co-production. So young people from MH2K and the Parent Carers Forum have been involved in the design of this website from the very beginning. And they've told us their views down to the language we've used on the website, the branding, the imagery, and the content, which is really exciting. So I'm just going to give you a quick overview of the site and then take any questions. So when you land on the site, you can tell the site what type of user you are, and you can switch between these different users, a young parent, a young person, a parent carer, or a professional. And there is a focus in particular for education professionals, but it's also accessible for health, social care, and third sector. So I'm going to take you through the young person view, and you will land on this page and it will ask you, what do you need help with? And you will see a range of 20 different common mental health topics. And young people have worked with us and helped us to make this language really accessible, so that when we say things like bullying or anger, they will expect what they see in the content. So since the launch, one of the most frequently visited pages has been the page on anxiety and panic attacks. And so I'm going to take you through that one as an example of what's in the pages. So when you land on the page, it drives you initially to self-help information and resources. And depending on what type of user you are, it's similar content, but the language and the resources are tailored for you. So this content is tailored for young people. Predominantly sort of 11, 12 plus would be using this for themselves, and younger children, the parents might be accessing the content for or with them. And if you're a professional, there will be professional focus in the language and the resources. So there's self-help information in terms of psychological education about the topic. As much as possible, there's video content and bullet-pointed, accessible top tips. As much as possible, those videos are from local services. So we have resources from, for example, MH2K, when they have created resources on particular topics. If you want to learn more at this point, there's then links to local services such as Health for Teens, Health for Kids, and national resources that we have curated, such as NHS mental health pages and the Young Minds website. If, however, you want to get some help with this topic, you can click Get Help, and it will take you to a curated list of services that can offer you support to do with this topic. So some of them that you see immediately will be specific services for that topic. So for example, No Panic is a service that helps with anxiety and panic attacks. And you will see if the service offers you city and county access, what age it offers services for, and what it actually can offer you. So for No Panic, they offer a phone and email helpline. If you click on this, it will take you to the page on their website where you can contact them. However, there are also a range of services who offer support across all of the topics. So we have this button here which will show talk to someone about the topic. And if you click on it, it will take you to a wider list. And some of you might recognise our very prominent local partners like Base 51 and Cooth on this list. You can filter this list whether you're in the city, the county, or everything. And if you're not sure, there's a postcode check where you can put your postcode in. Now, on this page, if you are a parent or carer, there's also additional support for adults as well as help for your child. So if you are a parent or carer, you can switch the view to support for yourself, for your own mental health and well-being. And the same is true for professionals. So there's content and support there for professionals to support their own well-being as well. So on the site, We are also linking to the Senior Mental Health Lead training, which is being rolled out at the moment. And in terms of next steps for Not Alone, that's the next phase, moving into phase 3. So the very first cohort of our Senior Mental Health Lead training has just commenced, and it will run across the academic year. We have 105 schools signed up across the city and county, and they've just completed the part 1 session in November. So all the information is coming in through Not Alone, and the creators of Not Alone, mental health professionals across the city and county, are the people delivering on those training sessions. So there's also a feedback option on the website. So we're continuously trying to develop, and we are getting regular reports of the visitors and analytics for the website. And there's also an urgent mental health support option. So if someone comes to this site at a point of crisis and they're not in a place to be able to browse and find what they need, they can click on this banner and it will direct them to either 999 or A&E or the local mental health crisis phone line that was in the previous slides. There's also a bit of information about Not Alone, and there's a short video which basically is giving you the information I've just shared with you, a guide around the website, what's on there, how it works, and just a little bit more context about the key partners, etc. The only other thing I wanted to show you is that it is mobile responsive, so it will adapt if you are on a mobile view, and you'll be able to browse through the topics. And if you are on a mobile view in one of the topics, the Get Help Now button will always be at the bottom of your screen. So at any point, if you're in this topic, you can click the Get Help Now and it'll take you to those services. Okay, so that's a very quick overview of Not Alone. Hopefully you all have the link to the website, but that's the URL at the top of the page, notalone.org.uk. And we also have a Twitter account, so you can follow us on Twitter, and we're really trying to use the Twitter account at the moment to generate awareness of the website and to get the branding out there. You might have seen our media launch recently with Not Alone posters across bus stops in the city and county. So that was an exciting time for those of us involved in the project. So I've really enjoyed being part of it. I think it's been co-production and I think it's been very well received initially. Our next step is increasing the users and ultimately getting young people generating some content for us.
Thank you, Orlette. Don't go away. I'm sure there's going to be plenty of questions for you. Thank you for that. I think it's one of those things that's going to generate a lot of interest. And I was struck by our huge success in our access success, where we're up to 53% compared with a target of 35% in terms of access for children with mental health problems to access support assessment. I think my impression of Not Alone is that it could be like a one-stop shop, eventually including all things that are required and direction to those things throughout. I would certainly enjoy directing my GP colleagues towards the use of it and the spread of it through the primary care networks. And I've got a meeting tonight, so I'm going to highlight it at the primary care network meeting for Nottingham West, and that might help start to spread it or later. Then we can get it to the 20 PCNs and then spread it from there. I think the options on it are fantastic, from acute to less, and to involve the parents in it as well is absolutely fantastic. I'm going to open it out now to questions. Anybody who's got a Councillor Tideswell.
Thank you, Chair. It's so reassuring knowing that funding has been made for the schools, because I know that the need is there. The other thing I'm not aware of is the funding for early learning centres, Akershire Start. I know that they have always been at the forefront of helping these issues, but with the advent of actually losing managers and financial restraints put on them, one wonders if they are able to be as proactive now as they used to be. I've been a big advocate of early learning centres for a long, long time, and I have a lot of admiration, especially in the areas where I am councillor for as well, because they do tend to be deprived areas, and there are a lot of mental health issues around there. Thank you.
Thank you. Well, we'll take a few more questions and then we'll come back to the answers. Councillor Martin.
Yeah, like I said earlier in the meeting, I found this Not Alone website earlier, and it's great, and I've shared it around a lot across from Mansfield, Kirkby, Sutton, Hucknall, and so let's see where it goes. You know, I forgive my ignorance, but will it be versatile enough to go on Snapchat and Instagram, because they're the younger generation's media format. You can tell the older people are on Facebook and Twitter. So, you know, it's just a generational thing, isn't it? And I think perhaps something that, like a photograph that could start to be shared, especially because Snapchat disappears, doesn't it? And Instagram is like a story that goes on into it. So, you know, I think that might be a better way of promoting it across. I've always said before, when the County Council have done stuff like this, it's about whether it's interesting enough to catch people's imagination. And that is, because you've interacted with members of the public and children, probably, you'll get that. And I'm hoping we're going to put it out across the primary school network, because obviously most of the primary schools are still County Council owned. So we have got a way of putting it out. And like I said earlier to the committee, you county councillors can filter it out, because they are the highlight of social media across the county, or they ought to be, you know. And then you've got your parish councils and your district councils as well, where they've all got Facebook and Twitter accounts, and I think that's the way you can filter it out, because it'll soon start to get picked up. And anything that helps children in need like that is going to be surely beneficial to everybody. So I think well done.
Yes. Any further questions in that? I can say that some of the more traumatic consultations are when a mother brings in their child and rolls up their sleeves and shows you where they've been cutting their arms, and there's a look of desperation in their faces to what can I do, doctor, to help. Back to you, Orlaith, to answer a few of those questions.
Yeah, so in reference to people like early learning centres getting involved, and also in reference to the move to Instagram and Snapchat, the current development phase is funded up until March 22, and we are just in the process of getting funding from the city, the county and the CCGs to make a post longer term for the further development of the programme. So things are looking really good. We have agreement from the various funding bodies, and we're also talking to the current NCC comms and IT department that we have commissioned about whether they could give us something longer term. We're thinking 3 to 5 years. And as part of that plan, the things we would like to do as a priority are engagement with young people with a focus on Instagram and Snapchat. So we do have an Instagram account for Not Alone at the moment, but it's not very active, recognising that we haven't got the resources yet to do it properly. So that is a key priority. And we hope that what we're going to do is have a project manager in place for Not Alone over a 3 to 5 year period, and they would have a development plan for Instagram and engagement with young people. And the other part of that role, hopefully, will be a single point of contact for new content. So if services want to update Not Alone, if they want to put new services on there in the Get Help section, we'll have a system there to put new things on there. So hopefully over time it will develop. At the moment, you can contact myself if you're in the County Council, or Maddie if you're in the city, and we're just updating it as we go along. But hopefully we're going to have a more formal updated system for new services to get involved, and we welcome that absolutely. So anybody and everybody across the city and the county who's offering mental health services for our young people, we want them on Not Alone. So any services that you and your colleagues are aware of, tell us about them, get us in touch with them, and we'll get them on there on the Get Help section.
Thank you, Chair, and it's more of an observation than a question. Yeah, and the observation is this is an exceptional good piece of work. It's not a Notts County Council piece of work, it's a piece of work across the partnership, across health, the voluntary sector. We've heard the voices of young people and their parents in developing this. It deserves, frankly, national recognition and a national award. And I thank Rachel and Orla and the team that have worked on this. It is an exceptional piece of work, not least of all because we actually asked our children and young people what it was they wanted in terms of accessing advice and guidance, and they told us they wanted something that they could access when they wanted it, where they wanted it, and how they wanted it. And what this allows young people to do on their phones, is to do that, whether it's at midnight, 9 o'clock in the morning, on the way to school, on the way back from school, or when they're sitting dwelling on kind of what they're facing. And it allows them to choose just how much advice they do take and what their next steps will do. So this is an excellent piece of work. Thank you, Orla. Thank you, Rachel. It is something that you should really be proud of as a Health and Wellbeing Board, because the commissioning of it, if you go back far enough, emanated from this board.
Yes, I think you get that sort of feeling as you look around that people think, if this was on the Dragon's Den, all 4 dragons would be bid in to do it. It's got that feel about it, and I think we're all quite excited about it. I'm going to go on to it and see how user-friendly, etc. it is. So I'm going to thank Rachel and Orlate for that, and move that we go to the recommendations on page 100. Councillor Turner, can I have a seconder for that?
Yes, I'll second that, Chairman.
Okay, all in favour? Thank you very much. And we'll move on to item number 9, normally considered to be one of the least exciting elements, but it is our work programme, and it is increasingly important as we move forward. The place of the Health and Wellbeing Board as it positions itself going forward into the integrated care service, and its influence upon the integrated care board has never been more important. The things that we decide, the joint strategic needs assessments that we bring here, and the strategy that we develop over the next number of months will shape funding throughout Nottinghamshire for years to come. And it's exceptionally important that the work programme brings forward the joint strategic needs that we want to see reflected. We have a statutory obligation to do that. It also should reflect, as we go forward, work around board membership, particularly place-based partnerships, primary care networks, etc., the deliverers on the ground through which the Health and Wellbeing Board has a unique opportunity to channel and develop, and it's something that we've been looking for many, many, many years. The Health and Wellbeing Board was statutory in 2013, and whereas we've had wonderful joint strategic needs, and we've got 44 of them live on Nottingham Insight at the moment, where we've had wonderful areas where we've done partnership work and done tobacco declarations and mental health concordats. This is our first real opportunity to direct the funding through the ICB directly out into the communities to influence health and wellbeing and public health, and I'm quite excited about it and would like to see the work programme reflect what we want to see developed in our communities going forward. Really, really important, and to bring in the place-based partnerships which will be working on the ground to deliver those. Jonathan, I know you're probably as excited as I am.
Thanks, Chair. Well, actually, I am, and Chair, I note that coming up in March, yes, we've got a meeting by which time we should have at least in draft that joint health and wellbeing strategy, and a meeting in March where we've got the opportunity to discuss the delivery of the strategy and also its monitoring and evaluation. I think we've had a good example this afternoon of these 3 papers that have given us an opportunity to take a look at progress on some really important agendas. And that in general has been the way that the board has kept track of progress. But before we launch into the next 4 years, I think it's really important that we just reflect on what's going to be the best way to monitor progress going forward. And are there some different or other things that we need to do alongside that as well? So I'm really just wanting to underline to partners the importance of that meeting. Yes. In terms of thinking about how we monitor and evaluate, but also the importance of that meeting in terms of how we go about delivering the strategy. There have been discussions already starting off with NHS partners in the place-based partnerships. Yes. And there's going to be some really important key links between the Health and Wellbeing Board and the place-based partnerships, yes. And as part of that with the districts and boroughs. So this is my big sell. I think this is going to be an important meeting that we have in March. And I just wanted to underline that. Thank you.
They're all important, Jonathan. They're all important. But yes, this is a big one. And when we go out and we meet and talk to people, there haven't been place-based partnerships before. There haven't been organisations looking to involve outside the traditional NHS and move into the communities. They don't know how to deliver that because they've never delivered it before, which means that the direction and the help from the director through public health has never been more important in order to make that a success. And that is part of our duty, is to make sure that they're successful and to be there as a partner as we go forward. The roadshows have also started on Monday, Jonathan, in Gedling. And they're going to continue around the whole of the county, including as far north as Bassetlaw, in the town hall in Retford. And this Friday, I think between, is it 4 and 5? We're at the Beeston Library. Get your ticket early. You know, I'm going to make some disc 2 for 1 if you get in before the day. But it's a fantastic opportunity for the people in every area to actually contribute to what we're going to be doing going forward. And I cannot stress that this is an opportunity that if we are not directing it, if we are not leading it, if we are not influencing it, you can't come to the party after the party is finished. You have to be there at this stage, and it's absolutely crucial. Councillor Martin.
Yeah, I brought it up, I think it was health scrutiny. But I'd be interested if we could implement a screening programme at secondary schools for sudden arrhythmic death syndrome, because that's something nationally that's not done. And I think as part of our new forward-focused partnership, the way the ICS is developing, I think that would be highly advantageous, because I think it's the next one down from suicide for death rates, I think.
Arrhythmias or undiagnosed cardiomyopathies, whereas they go out and they play football and they drop dead. And yeah,
I think it'd be worth if we could look into it, because it's quite, yes, there are more people that die from it than you think.
There is a lot of physical intervention in terms of having to do an echocardiogram and things like that, but I certainly want to go back to the CCGs with. Anybody got any other suggestions before we close the meeting? Thank you very much indeed. 3:45, hey? Have we not made your day today? Hey? Thank you all very much for attending, and we'll see you at the next meeting.